let's move on to ALK for the sake of time. ALK mutations, second most common driver mutation are ALK rearrangements identified in non-small cell lung cancer, adenocarcinoma. The story of ALK, I think, is emblematic of precision medicine. We identified ALK mutations. It only took 4 years to develop crizotinib. The pace of drug discovery is really quite rapid these days. We, of course, have first-generation drugs. Crizotinib is now approved for a first-line indication. That may change. But we have next-generation ALK inhibitors that are structurally different, a little more potent. They're able to overcome crizotinib resistance, which has led to more ALK inhibitors, crowded space. We have now several drugs at our disposal, with more coming down the pike. Mark, I'd just ask you to kind of give a highlight of where we are with crizotinib and ROS1, which is another rare mutation, but then kind of where we're heading with the ALK-directed therapies, ceritinib, alectinib, its potential to cross the blood-brain barrier, and some of the data we may see tomorrow with brigatinib.
So in many ways, I think everybody looks at it as analogous to the EGFR experience, but it is different in a few ways. I think the first thing is, I asked Sarah's colleague, Katie Politi, in the laboratory, is there any difference in the laboratory from among the first generation EGFR TKIs, and even the second generation? And she said no. However, these drugs are different. Their potency against the target is quite different. And I believe as a manifestation of that, the patterns of resistance are different. There is not a common gatekeeper mutation in 60% of patients that have a acquired resistance to crizotinib. It's a different story. There's a complicated pattern of acquired resistance, and yes, there are some gatekeeper mutations, but it's a very, very different story. But a lot here has to do with potency of the drugs, and I think all of them are very potent. The second thing is the ability of a drug to treat an established brain metastasis. And I'll make the broad statement, as good as a drug is in the chest, it's as good in the brain, every single drug. Yes, theoretically there may be some differences, but if a drug works in the chest, it's going to work in the brain. And it's really uncertain that any of these things for an existing brain metastasis works better. But they clearly, somebody getting ceritinib or alectinib gets a very good, important response after failure on crizotinib, and it's probably because they're more potent. How do we sequence these drugs? I mean, we just have no idea. However, just like in renal cell cancer now, where there are a lot of kinase inhibitors, and they're starting to look at what's the best one, we're starting to do that now with the ALK inhibitors as well. And already there's been a press release comparing of a trial comparing crizotinib to alectinib. And the press release says an improvement in progression-free survival, and there'll be a presentation at the American Society of Clinical Oncology meeting that details that as well. So there are differences in toxicity, there are differences in potency, and right now, I guess if you believe that press release, the better PFS would be with alectinib. The tolerability of alectinib is excellent. If you've treated patients with both alectinib and crizotinib, by and large, they tell you the alectinib's easier for them. And I have a feeling that alectinib's quickly going to move up to the first spot. But it is a slightly different situation. I'm happy we have all these choices. I think there are differences in toxicity, obviously. I think we've all seen that. Hepatic toxicity with one often is not repeated with another, and that's a nice thing with those patients that have hepatic toxicity or edema. But it's somewhat different, and it's something we're going to have to work out.
Yeah. You mentioned brain metastases, the ability of alectinib and ceritinib to cross the blood-brain barrier to elicit responses in the brain, and also kind of parallel to being able to elicit responses in crizotinib refractory patients. Up to 50 to 60%, in the trials at least, up to 50 to 60% of all crizotinib refractory patients do develop brain mets at some point. My question is, do we need to surveil patients with routine brain MRI? Is this a special population where we need to routinely be doing brain MRIs every 6 months, every 9 months, every 12 months to pick this up earlier?
That's a tough question because this is a very common problem in all lung cancers. And many feel that with longer survival, that this becomes more common. And who do we have with the longest survival? It's ALK-GFR, it's ROS1. So by the nature of those illnesses, we are going to be seeing more brain metastases, and they're a huge problem. Surveillance, I'll take my experience in small cell lung cancers. Ultimately, most of the tumors we found on surveilled patients happen between the scans. And my guess is if we started doing that, we'd probably get the same thing. So I'd probably be wary of doing surveillance on patients and be, of course, very quick if there were a symptom to jump on that. And by the way, these drugs, of course, are very effective when you have a brain metastasis, just like they're effective in the chest. And I have to throw in a word for chemotherapy. You know, there was a beautiful paper in clinical cancer research, I guess about a year ago now, from the French group, giving paclitaxel, carboplatin, and bevacizumab, 63% response rate in the chest, 63% response rate in the brain.
Right. So there's activity.
But it's exactly the same with
Right,
ceritinib
right.
or alectinib when you go into the reports of those drugs as well.
I think
Please.
I think that these ALK patients are different.
Oh, no, I absolutely.
So,
oh, I'm sorry. I
because
didn't
they are
mean to imply that. They are different. Yeah.
So I think that to see 50 to 60% incidence of brain metastases, and then we are able to treat them with the second generation and third generation inhibitors, I think that we should be looking for this so as to change the treatment in this group of patients.
Yeah, I think it's
ALK is involved in neural development too, so we
Right.
don't understand what guides these things to brain metastasis. The programs that guide these cells to grow well in the bone, you cannot escape the fact that the ALK is involved in the neural thing, and whether there's a trophism in the brain is something we cannot forget.
And with these longer survivals that we are seeing with these ALK patients, and the question about sequencing, I think, is a big one here. Because if alectinib, which is going to take the first-line position at this point in time as based on the JLX trial, which is being presented on Monday, that there is a significant improvement in overall progression-free survival against crizotinib. The question is that what would be the second, or what will work after alectinib? So we really do not know what is going to work in
Pemetrexed.
alectinib.
Pemetrexed, I agree.
I think that then,
Bevacizumab.
though we are,
Bevacizumab.
as we said, that we have now 4 or 5, and 2 or 3 others are also in development.
Yeah.
I think it'll be a big challenge how to sequence these ALK inhibitors in our community practice, in our practice.
I think it's the same with EGFR though, right?
Yeah,
do you use your
I was gonna say.
best drug first, or do you use one that works first, and then another one that works
Well,
second? We don't know. We don't know, right?
Well,
don't
we
know
just said that if supposing osimertinib becomes
Is
the
first,
first line,
what do you do second?
will any of the first
Right,
and second
exactly.
generation inhibitors even
I
work?
think it's the same story there.
Yeah, I think there's a lot of unanswered questions with these genotypes. One more question.
But it is impressive that alectinib has shown superiority, at least it's early, though the phase 3 study, which is being conducted outside of Japan, has completed accrual, and I think we'll get more data.
Right.
And then there is brigatinib also.
We'll
which,
have some
we will see
information
the
on
data.
tomorrow.